Hello, I'm Nancy Berliner from the Division of Hematology at Brigham and Women's Hospital, and I have no disclosures. So this is sort of summary talk of the lectures that you've heard in the hematology section. And rather than just repeat what the other speakers have said, I've tried to put this together in the context of how I would test patients who have the various disorders that you've heard discussed in the lectures. And it's primarily oriented around high counts, low counts, and bleeding and clotting. So starting with anemia, this should look familiar from Dr. Chebe's lecture, that the center of the evaluation of anemia is the reticulocyte count, or the reticulocyte index, which is just a correction of the reticulocyte count for the hematocrit. So if you have a reticulocyte index or a reticulocyte count of 1% with normal red cell survival and a normal hematocrit, that's normal. But if your hematocrit falls for whatever reason, the reticulocyte count should rise, and in a normal healthy bone marrow, you should have a reticulocyte response, so the reticulocyte count should go up. So the evaluation of a patient with anemia is really based on the reticulocyte count, and most people usually say the first thing they looked at the end is the MCV, but it's important to recognize that the mean corpuscular volume is only informative in patients who have hypoproliferative anemia. So if you have a high reticulocyte index, that really is only consistent with either hemolytic anemias, which can be congenital or acquired, or blood loss. And all of the other analysis is based on hypoproliferative anemias or anemias with a low reticulocyte count or inadequate reticulocyte response. And that's when we look at the MCV, whether it's low, medium, or high. So if I'm looking at a patient with anemia, there are a few tests that I automatically do, which cover most of the waterfront here. Obviously, if it's a high reticulocyte index, that's a very different set of tests, but with a low reticulocyte index, the main tests that I check are iron studies. That's really regardless of the MCV, because iron deficiency is the most common cause of anemia, and it's the most common cause of anemia regardless of the MCV, although classically severe iron deficiency is associated with microcytosis. I find that the erythropoietin level is extremely helpful in many cases of anemia with low reticulocyte count, and I'll discuss that a little bit further. B12 and folate, which again are usually associated with macrocytosis or megaloblastic changes, but because the people who have nutritional defects in B12 may also have nutritional defects in iron, it is helpful to know if the B12 level is normal. And finally, I usually include assessments for inflammation, a CRP or a SED rate, mostly because it's very important for the interpretation of the level of the ferritin. Ferritin is an acute phase reactant and is affected by inflammation, and so may be falsely elevated in a patient with iron deficiency in the setting of inflammation. In true iron deficiency, one cannot raise the ferritin over about 100, but if you have someone with a borderline ferritin and an elevated inflammatory markers, they're likely iron deficient. So here's the interpretation of the iron studies, and the main purpose of this message is to distinguish iron deficiency from the anemia of inflammation. So in the anemia of inflammation, you get elevation of the hormone hepcidin, which immediately lowers the serum ferritin. So the serum ferritin is not terribly helpful. It's primarily reflective of the acute setting of the patient, and so it may be very low if the hepcidin level is high. It also can be elevated falsely if the patient has just ingested iron. Patients on oral iron who decide before they come to get their blood tested that they haven't taken their iron in a little while and they take it will have an elevated serum iron. So what is really effective in evaluating the level of iron stores is the ferritin. And the ferritin is the main reason, the main way in which you distinguish iron deficiency, where it's very low, from the anemia of inflammation, where it's normal or usually even high. But again, that is with the caveat that one needs to look at inflammatory markers to make sure that it isn't falsely elevated. So the anemia of inflammation is characterized by low iron and TIBC in the setting of an elevated ferritin, and is associated with a whole range of clinical disorders and is related to impaired erythropoietin responsiveness of the hematopoietic stem cell, shortened red cell survival, and impaired iron mobilization. The important thing of measuring the EPO, though, is that erythropoietin is also very important in anemia in the elderly. And obviously, many of the patients that are referred to you are over the age of 65. And over the age of 65, 10 to 12% of normal individuals will have mild anemia. And it turns out that EPO secretion and EPO responsiveness of hematopoietic stem cells is altered with age. So if you have a cohort of healthy, non-anemic individuals over the age of 65, their EPO levels rise to maintain their hematocrit because the hematopoietic stem cell is less responsive to EPO. This is probably a variant of anemia of inflammation because inflammatory markers rise with age. In those patients who have diabetes or hypertension, the slope of the rise is depressed because of the long-term effects of diabetes and hypertension on the kidney. And so anemic individuals are ones who have a failure of the normal compensatory rise in EPO levels, reflecting age-related comorbidities, most commonly renal insufficiency. This does not require that the creatinine be abnormal. So even in the setting of a normal creatinine, the erythropoietin level may be extremely helpful in interpreting anemia, especially in elderly patients. Hemolytic anemia puts you in a different category. Hemolytic anemia can be hereditary or it can be acquired. Hereditary hemolytic anemias are usually diagnosed by looking at the blood smear and evaluating the hemoglobin levels. And the most challenging are those patients who come in with acquired hemolytic anemia and the requirement of distinguishing immune from non-immune hemolytic anemia. That was reviewed by Dr. Chebe in her lecture as well. And the one test that I wanted to go over and remind you about is that the central tool for evaluating hemolytic anemia is the Coombs test. With warm hemolytic anemia, you will see IgG or IgG-NC3 on the surface of the red cell, and it is an IgG-mediated hemolysis. Can be related to drugs, but also can be related to malignancy, and many of these patients have idiopathic autoimmune hemolytic anemia. And this is the form of hemolytic anemia that responds to steroids and rituximab and splenectomy. It's important to distinguish that from anemias in which the direct Coombs shows only C3 on the cells. Those are typically cold antibodies, as we refer to them. They're usually IgM antibodies. They bind in the cold, which is why it's called cold autoimmune hemolytic anemia. They bind in places where the temperature may be a little bit lower. And the IgM binds to the surface and binds complement, and then as the blood is warmed, the IgM falls off. So all you see on the Coombs test is the C3. And the most important reason for distinguishing warm from cold antibodies is that they do not respond to steroids or splenectomy, although they do respond to immune suppression with rituximab. Okay, so then I'll move on to leukocytes. So the differential diagnosis of leukocytosis, as I told you in an earlier lecture, is that most leukocytosis that you will see is secondary to other illnesses. It can be related to infection or stress or certain drugs. It can be reflective of chronic inflammation. And most patients post-splenectomy will have an elevated white count because the spleen is a major site for sequestration of white cells. And it's only after ruling all those out that we consider primary hematologic diseases like chronic myeloid leukemia or other myeloproliferative neoplasms. So in working up leukocytosis, there really isn't very much that needs to be done. It's important to remember that neutrophilia is usually reactive, indicative of a normal functioning bone marrow, and therefore you don't very often need to do a bone marrow. The most important thing is to repeat the white count, since a transient elevation in the white count or an artificial elevation is possible, in which case you don't want to go chasing an otherwise normal result. But then the patient should be evaluated carefully for acute or chronic infection or inflammation. And I always, no matter how unlikely it seems, will do fluorescence in situ hybridization for BCR-ABL, since the one diagnosis you never want to miss is chronic myeloid leukemia. And in those patients where you feel pressed to do a bone marrow, you should be sure to culture it, since you want to rule out granulomatous disease and fungal infection in the marrow. The workup of neutropenia is usually performed by a hematologist, but there are multiple forms of neutropenia. There are the congenital neutropenias, which we discussed, which can be benign, ethnic, and familial neutropenias, to be distinguished from severe congenital neutropenia, which is a disease that's usually diagnosed in early infancy. Cyclic neutropenia, which, as we mentioned, is related to the same mutation that causes the most common form of severe congenital neutropenia. And other rare disorders, primarily immune deficiency disorders in childhood, that can be associated with neutropenia. And then acquired neutropenias include autoimmune neutropenia, drug-induced neutropenia, chronic idiopathic neutropenia, and then finally at the bottom, primary marrow syndromes, where usually neutropenia is not isolated, but it can be a marker for myelodysplastic syndrome or aplastic anemia. So how do we work up neutropenia? If it is a baby or someone in whom you suspect a congenital neutropenia, and some of these patients do end up not being diagnosed till later, the most important thing to do is to do molecular diagnosis for the elastase gene, or ELANE, or HAX1, which are the two most important causes of congenital neutropenia. There are some places where they advocate for testing for Duffy antigen negativity in suspected ethnic neutropenia, especially if the ethnic background of the patient is not clearly one that is associated with ethnic neutropenia. However, in the absence of seeing that, someone with chronic neutropenia or with multiple family members with neutropenia can still be assumed to have benign constitutional neutropenia without further workup. If you have an acquired neutropenia, the approach is usually to stop any potentially offending drugs, although in the setting of mild neutropenia that is probably dose-related and drugs which the patient can't afford to stop, if the neutrophil count is not dangerously low, they can be continued. I include flow cytometry, looking for clonality to suggest a lymphoma, or to look for large granular lymphocytes, which can mediate neutropenia. I do serologic tests for anti-nuclear antibodies to rule out lupus, since over 50% of patients with lupus will have a low white count. As I discussed in my lecture, I do not recommend checking anti-neutrophil antibodies because they're not very reliable and have not been well validated as a way of diagnosing immune neutropenia. And finally, if the neutropenia is new and other obvious offenders are not identified, I think the patient needs to be ruled out for myelodysplastic syndrome, either using next generation sequencing approaches or bone marrow examination. Okay, so now we'll talk about clotting tests. So the test of the coagulation cascade include the prothrombin time, the partial thromboplastin time, the thrombin time, fibrin degradation products, D-dimers, factor 13 screens through clot dissolution, and the mixing study. I won't talk about all these, but the important ones for me are the PT, the PTT, and the mixing study. So what causes an elevated PT? Less than 30% of factor 7, which is the only pathway that is only protein that is really detected and sensitive to factor 7, even though it also tests the common pathway or fibrinogen. And so the PT happens to be extremely sensitive to low levels of factor 7. If you have inhibitors of fibrin polymerization, as in DIC, where you have a lot of fibrin degradation products, you can elevate the PT. Inhibitors are factor 2 or factor 10. And if you are markedly overtreated with heparin, eventually the PT will also rise in addition to the PTT. And the most common causes are naturally occurring vitamin K deficiency, medically induced vitamin K deficiency from warfarin, and liver disease with failure to make the liver-based factors. And the reason it's so sensitive to factor 7 is because factor 7 has the shortest half-life. Causes of the increased PTT is also any factor level less than 30, but actually it is that is with the exception of factor 7 and factor 13. And again, it is affected by fibrin degradation products, other kinds of inhibitors, and heparin. And the most common causes are congenital or acquired factor, congenital factor deficiency, acquired factor inhibitors, DIC, dysfibrinogenemia, and again, the lupus anticoagulant, which we'll come back to. So the mixing study is really the most important test for distinguishing factor deficiency from inhibitors and should be the first test that you move to if you are trying to evaluate why someone has an elevated PTT. And this is just an example showing you what you can expect from mixing one-to-one the patient's plasma with normal plasma. So if the patient has a PTT of 70, and he has an inhibitor or is factor deficient, it'll be 70. And you can't tell from looking at the patient which one of those things is true. And the same is true with normal plasma. There will again be normal. So if you mix them one-to-one and they're factor deficient, since you will need less than 30% of any factor to make the PTT normal, it will normalize. And so it will indicate that really what's missing is a specific factor that can be replaced. On the other hand, if you have an inhibitor and you had a one-to-one mix, you don't correct. And that's because the inhibitor will usually be of sufficient titer to neutralize the normal factor that is added in the mixing study. So we'll come back to that when we talk about the lupus anticoagulant, but I will start by talking a little bit about other hypercoagulable states and how we evaluate for them. So the risk for hypercoagulable states can be inherited abnormalities of the clotting cascade, but far more common are acquired, since obesity increases the risk for hypercoagulability and is much more common than the very small percentage of people with clots who actually have thrombophilia. And all of these states are additive. So if you're obese and you're pregnant and you have surgery, or you're obese and you have surgery and are at bed rest for several weeks, all of those things add to your risk of venous thrombosis. But the real question in deciding how to test a patient, who to test, and how long to treat them is whether their venous thromboembolic event is provoked or unprovoked. If there's a clear precipitating factor for the event, such as being put at bed rest or having major surgery, then in general, there's really no point looking for an inherited reason for a person to have a clot. Because you can explain the clot and you're not going to treat that patient long-term once the inciting factor has disappeared. On the other hand, if you have an unprovoked VTE or an idiopathic VTE, that is something which you might consider doing a hypercoagulable workup, and we can discuss why you would. But the fact is that regardless of whether the patient has an identified hypercoagulable state, an unprovoked venous thromboembolic event should be a reason to consider long-term anticoagulation. So the hypercoagulable workup typically includes tests for factor V Leiden and prothrombin 2210, which are much more common than the other mutations, but also are very low risk factors for VTE. So patients with factor V Leiden don't clot usually just because they have factor V Leiden, but may also clot because in the setting of factor V Leiden, they get pregnant or they are put on birth control pills, which raises the risk of thrombosis. There are also functional assays of antithrombin 3, protein C and protein S, all of which are quite rare. And we do not encourage testing for homocysteine, factor VIII, factor 13 polymorphisms, and other rare variants, which we really don't think have that much of a contribution to thrombosis. So the lupus anticoagulant is important to recognize because it prolongs the PTT. But unlike causing bleeding, it is actually a risk for thrombosis. It was discovered in lupus patients in the early 1960s, and that's why it's called lupus anticoagulant. However, the vast majority of patients who have lupus anticoagulants do not have lupus. It's unrelated to bleeding, and it's defined by prolongation of the PTT and behavior as an inhibitor in a mixing study. And because these antibodies are mostly directed against phospholipid, it can be neutralized with adding excess phospholipid. And although it is usually an antiphospholipid antibody, not all antiphospholipid antibodies act as lupus anticoagulants. So you need to look for the antibodies and for the lupus anticoagulant. And of course, it is a risk factor for thrombosis, but the actual prolongation of the PTT is reflective of the fact that the PTT is performed with a measured amount of phospholipid. Phospholipid in the body is provided by platelet membranes, and you can't have enough antibodies to prevent you from activating clotting, but because the plasma is for the PTT is deprived of platelets, use platelet poor plasma and a measured amount of phospholipid, the antibodies will neutralize it in the test tube. So that's why it's not associated with bleeding in vivo. So the tests for antiphospholipid antibodies include the lupus anticoagulant, which is screened by using functional clotting assays using a PTT and the dilute varsulfide preventum time, and it can be confirmed by either adding back platelets or adding back excess phospholipid and seeing that the PTT corrects. And the most common forms of lupus anticoagulants are anticardiolipin and beta-2 glycoprotein 1 antibodies, and they should also be tested separately because there are some patients who will have these antibodies but won't have a lupus anticoagulant, and vice versa. You may not detect the anticardiolipin antibodies and still have the lupus anticoagulant. And the lupus anticoagulant, as it turns out, is quite common. And many laboratories who are doing pre-op testing of patients will automatically look for lupus anticoagulant in the face of an unexplained elevated PTT. These are of no significance in terms of bleeding with surgery, and mostly is associated with thrombosis. So who should be tested? Well, this is highly controversial. The indications for a possible hypercoagulable state are thought to be early onset of thrombosis in people under the age of 50, recurrent thrombosis, especially recurrent thrombosis when it occurs in the setting of adequate anticoagulation, positive family history in first-degree relatives, or clotting in unusual patients. However, it is not recommended to test everybody who comes in, especially in the ER with a clot. And there's really no rush to diagnose one of these syndromes because everybody who has a clot needs at least 3 months of anticoagulation, regardless of their thrombophilic status. So why is it the controversy? Well, the reason is that there are no data that says that the results should affect care. As I mentioned earlier, the real decision about how long to anticoagulate someone should be based on whether they have a provoked or an unprovoked venous thrombotic event. And in 2013, for example, the American Society of Hematology recommended that you not test anybody in the setting of a provoked VTE if there are strong risk factors identified. Also, it's prone to misinterpreting it. First of all, everybody who has a hypercoagulable state who may have had a partially provoked VTE. Most commonly, for example, women with factor V Leiden who are found to have a venous thrombotic event in the setting of birth control pills or in the setting of pregnancy do not require lifelong anticoagulation. However, in many hands, identification of one of these findings will make the physician commit the patient to long-term anticoagulation. The other thing is that if someone has an unprovoked VTE, they obviously have some risk factor. And so if you have negative results, that can actually be a problem because then they think, well, they're fine and they don't need long-term anticoagulation. And it's been shown over and over that the risk of recurrent VTE in someone with an unprovoked venous thrombotic event is not affected by whether or not they have a hypercoagulable state. So if you have a provoked VTE, it doesn't change. The exception is antiphospholipid antibody syndrome is almost always worth identifying because people who are triple positive for the antiphospholipid syndrome, i.e. they have a lupus anticoagulant and positive antibodies, should have long-term anticoagulation because their risk for recurrent thrombosis is very high. And the other thing is that there's really no point in looking for other sources of hypercoagulability in someone in the setting of malignancy, because malignancy is an important hypercoagulable state, and we recommended long-term anticoagulation in those patients unless they are rendered completely disease-free.